It's a pleasure to be back to give my fourth lecture for today. Before I start my talk, I want to make two confessions. One, I think you already probably pretty much understand. I tend to be rather dogmatic and authoritarian in my approach to lectures of this kind and other kind. The second confession, you may not be quite so, it may not be quite so obvious. I am 83 years old and I have CKD. This has great relevance to what I'm about to discuss with you. I've had CKD for 10 years. My eGFR 10 years ago was 58 mLs per minute per 1.73 meters squared, and my family doctor told me I had CKD stage 3 and that I was ill. I had a serious disease. Stage 3 is 3/5 of the way to the grave. I had normal blood pressure. I played golf 3 days a week. I drink good wine, eat good food, travel widely, and feel wonderful. But I had a disease, chronic kidney disease. That's my confession. So you will appreciate the fact that my talk is going to be very provocative and very unsettling to those of you who are believers in the idea of CKD. So let's start with this conundrum of diagnosis of CKD in the elderly, like me, some of the pitfalls, and some potential solutions. Now, I don't have to tell you that aging itself is a very complex and very poorly understood process, but it involves three things: genes, the environment, and chance. From the standpoint of chance, it's the unpredictable mutation in one tiny segment of the DNA that occurs as we get older. And the older you get, the more mutations you have, which then expresses itself in various organ systems. Actually, genes aren't, heredity isn't all that important in aging. It contributes only about 10% to the process. And it proceeds at highly variable rates, even in identical members of the same species. The rate of aging in identical monozygotic twins is as different as it is in dizygotic fraternal twins. It seems to be a fundamental process of cellular degeneration called senescence and faulty repair. And it is inevitable. All of us age. The only organism on this planet that does not age is the genus Hydra, which has the capacity to self-reproduce itself indefinitely. That's the only exception in biology. Now, all organs express the consequences of aging. And I imagine everyone in this audience can find something in their anatomy or physiology that points to their getting older. Loss of elasticity in the skin, which frustrates women terribly. Bones, nervous system, pancreas, muscles, lung, gonad, stomach, myocardium, blood vessels, I could go on. But for this audience, we're going to talk about our favorite organ, the kidney. And the kidney ages, just like all other organs age, and it ages in a very stereotypical way, probably the same that has been going on for thousands, hundreds of thousands, maybe millions of years. The phenomenon of aging in the kidney manifests itself as a decline in glomerular filtration rate and renal plasma flow, which occur in parallel beginning at about age 30. The peak GFR in your lifetime will be at around age 20 to 25. It doesn't get any better after that. And at about age 85 or maybe 80, the rate of decline of GFR may accelerate and renal plasma flow may actually fall more rapidly than GFR. Here is the phenomenon of GFR and aging as seen in the general community in yellow and in the healthiest of healthy living related donors who by definition are extraordinarily healthy. Extraordinarily healthy. GFR declines in both groups at about the same rate, at about 6 milliliters per minute per 1.73 meters squared per decade of life. In the last decade, I have lost 6 milliliters per minute of GFR, which is absolutely in the median value for all human subjects. This is the values of glomerular filtration rate measured, not estimated, but measured, in this case by inulin clearance or iohexol clearance in 633 living healthy donors at the time they gave up their kidney. What I show you here is the age of the subject in decades, the upper limit of normal, URL, and the lower limit of normal. That's a 2.5 percentile on either side, so it's a 95% confidence limit intervals for measured GFR, and on the far right, the median, or 50th percentile. At age 20 to 30, you are at your best, with a maximum GFR of about 136 and a minimum of 78 for a normal, healthy 20-year-old person. The median value for measured GFR is 107.5 milliliters per minute plus or minus 6 in 633 living donors. Note that the upper limit and the lower limit decline with aging such that the lower limit of normal falls below 60 milliliters per minute, somewhat over the age of 60. 60 milliliters per minute is the magical value adopted by KDIGO as a definition for CKD. Using that definition and measured GFR, a very large number of older people have CKD, including me. Well, what happens to other aspects of the kidney as we age? And I've been fortunate enough to work with the Mayo Clinic group for the last 8 or 9 years, and we've published a number of interesting findings studying all of the healthy kidney donors at the Mayo and Cleveland Clinic ranging from age 17 to 77. Fortunately, every one of these donors had a kidney biopsy at the time the kidney was removed and before it was implanted in the new recipient. So not only do we have gross anatomical information from CT scans prior to donation, we also have microanatomy in all of these donors, and there were over 1,200 such individuals, so it's not a small sample. Well, here's what happens. You see in these healthy aging kidneys, focal and global glomerulosclerosis. You never, ever see focal and segmental glomerulosclerosis. FSGS is not a phenomenon of aging in humans. It is in rats, but not in humans. There is a difference between rats and humans. Rats continue to grow throughout their lifespan until they die. Humans stop growing at about the age of 20 to 30 years. Now, they may become obese. However, they don't grow. Their height remains constant. Interstitial fibrosis and tubular atrophy is seen in arteriosclerosis. However, there is no relationship between these findings and the GFR in that patient at that time. The blue, the X's shown here on this scale represent two groups of patients. The red X's represent a high sclerosis score, and the blue circles represent a low sclerosis score. On the bottom is the age, and on the vertical axis is the measured GFR. There is no difference in measured GFR with more severe versus less severe. Renal biopsy does not predict what the measured GFR is with aging. And I'll come back to explain why that is true. However, GFR does decline around 6 milliliters per decade, just like it did in me. Now, there's been two postulates for how and why there is a reduction in GFR with aging. One is that there is progressive loss of glomeruli through a process of glomerular sclerosis and obsolescence with incomplete adaptation of single nephron GFR in the residual glomeruli. You see, if the residual glomeruli simply adapted to the loss of nephrons by increasing the value, GFR would remain constant with aging, but it does not, despite the fact nephron aging. Now, there is an alternative hypothesis that there is progressive impairment of the filtration capacity of individual nephrons, and that the decline in GFR is occurring at the individual nephron level without any necessary loss in nephron mass. Well, let's examine those postulates, and in man, for the first time, we can actually assess single nephron GFR. This has never been done before in intact man. It's been done in animals, lots. But this is the first time it was ever done in man. This was published a few weeks ago in the New England Journal of Medicine. I referenced that. I'm sorry I didn't reference it, but it's in the New England Journal of Medicine. The reason is we can do volumetric CTs in the patient before they donate their kidney. We do a biopsy of the kidney, and we do sections of the cortex and measure the density of glomeruli per cubic millimeter of cortex. And if we know the total volume of the cortex by simple multiplication, we can determine the total number of nephrons. It's just a mathematical, there's some correction factors for tissue shrinkage and the processing, but this has been well documented in animals to be a pretty accurate way of assessing total glomerular number. And if you know the total glomerular number and the measured GFR, you can calculate the single nephron GFR. That's just a mathematical. So here's what happens with aging and single nephron GFR and number. On the bottom is the age groups. On the vertical axis is the number of glomeruli per kidney times 10 to the 6. So this is in millions. And you'll see that at the young age, the average is around 900,000 to 1 million. And with aging, the number of glomeruli in total decrease. GFR decreases in parallel with the loss of nephrons. Therefore, there is about, over a 50 or 55-year span, a 48% decrease in nephron number, which amounts to about 8,200 per year, or 23 nephrons per day, about 1 nephron per hour. So in the course of this lecture, I would imagine about 250 nephrons are being lost by this audience, somewhere in that vicinity. 1 nephron per hour between age 20 and age 75. And this is stereotypic. It happens in all healthy aging people. So the number of nephrons you wind up with at age 75 is determined with what you start with at age 20. And not everybody has the same number of nephrons. If you were born prematurely or born with a body weight less than 2.5 kilograms, you're going to have far few nephrons than if you were born at a normal weight. So nephron endowment determines what the final outcome of aging is, because nephron loss during aging is constant over time. So anybody who's born with a body weight less than 2.5 kilograms is likely to develop CKD at a little earlier age than perhaps someone with a normal body weight at the time they were born. Here's what happens to single nephron GFR. That's the gray bar, vertical gray bar, not the white bar. As you would predict, it remains virtually constant despite a fall in GFR and nephron number up to about age 70. After age 70, there appears to be a spike in single nephron GFR, shown here, but this may be an artifact because very few patients in that age group are studied and they're highly selected. Nobody gets through the process for donation at age 70 having something else happen to them. So we're not quite sure whether this is or not a valid number. We'd have to study a lot more than 8 subjects to get a reliable data. But up to about age 80, despite the loss of almost 50% of your nephrons, your single nephron GFR does not change. That's interesting because in disease, when you lose nephrons, the other nephrons compensate. And single nephron GFR goes up. That's called hyperfiltration of residual nephrons, which participates in the damage of the kidney. Hyperfiltration is not a phenomenon that is responsible for the loss of nephrons with aging. I can say that with high degree of confidence and dogmatism. Okay, so nephrosclerosis occurs with normal aging. It can be detected on biopsy and by CT, shrinkage of the cortex, but neither the biopsy nor the CT decrease in volume explains the decline in GFR. But nephron number does explain the decline in GFR. What happens to those nephrons? Well, they undergo reabsorption. They slowly sclerose, and then they just disappear. That's been well described. So the aged global glomerulosclerotic parts of the nephron just disappear, are completely reabsorbed. And single nephron GFR is stable. I'd like to tell you that we know for certain that nephron endowment has an effect or no effect on the rate of decline in nephron number, but that's not been studied. So I have to say we need more studies to know the relationship between nephron endowment. But if you start with few nephrons, you wind up with even fewer nephrons. That we can say with some degree of certainty. Okay, so here's a postulate for you to think about. Maximum nephron number is fixed at birth by intrauterine nephrogenesis. Fetal dysmaturity reduces nephron number. This is the Barker-Brenner theory. The nephrons that are left when you're born do hypertrophy to some extent to compensate after birth. These hypertrophic glomeruli in low nephron mass states may contribute to the damage seen in low birth weight individuals. Global glomerulosclerosis, renal senescence commences at about age 20 years and leads to progressive nephron loss without further adaptation in single nephron GFR. So let's look at disease versus aging. 3 lines here constitute the change in age and the surviving and functional renal mass. I've drawn a nice line here which says the current CKD definition. That's that dotted line. Well, as you can see, the green line, which characterizes healthy aging, crosses this barrier at about age 60 to 65, depends on what you started with. But if you're diseased, it's going to cross it a lot earlier, particularly if you have a progressive form of disease. So by using this single arbitrary criteria, I can't tell whether you're this, or this, except this will occur at an earlier age than this. But it's impossible to tell with an eGFR of 60 in an 80-year-old person who has no other signs of kidney disease, no proteinuria, no blood pressure changes, nothing, whether it's healthy aging or disease. But KDIGO decided to call it all disease. They did not give you the choice. Here's their version of CKD. You will note here is G3A, mild to moderate reduction in eGFR, 45 to 59. With no albuminuria, it's not in the green zone. It's in the disease zone. Of course, as it goes further, the disease zone becomes red, high danger. With albuminuria, and I would agree with that, with high-grade albuminuria, even with a GFR that is consistent with normal aging, that is a sign of kidney disease because normal aging does not produce albuminuria. There is no focal segmental glomerulosclerosis. There is no intraglomerular hypertension. There is no glomerular hyperfiltration. There's no reason for albuminuria. My albumin excretion, by the way, is 15 milligrams per day, just to make you feel better. So in 2017, you can make a diagnosis in an adult. Anyone over the age of 20 years makes no difference, 20 to 90. If a single value of eGFR less than 60, repeated once within 3 months, is abnormal, even without evidence of any other manifestation of kidney disease, such as albuminuria, an abnormal urinalysis, or kidney biopsy. Is this a good definition of CKD? From my perspective, absolutely not. But it is the standard definition. Well, half of the adults over age 70 can be told they have CKD stage 3. Half of the adults, 50%. Is this beneficial to those patients? Are all age-related changes of the kidney consequent to a disease? No and no. Here's what happens to epidemiology. CKD is a disease of the elderly. This is the prevalence of CKD in patients over the age of 70, downward with age. So what we measure is 30 million people in the United States as having CKD. We're talking about old people. And a lot of them are perfectly normal old people. Yet, You will see in every publication on CKD, the world is awash with CKD. It is an epidemic of massive proportions. Most of it is just normal aging. I hate to tell you this because, of course, the whole field of nephrology is being built on the notion that we are awash in CKD. Well, if you look at the frequency of categories 3, 4, and 5 CKD in the so-called healthy elderly, this was done in Germany. If you use MGFR, measured GFR, the prevalence of CKD in a 90-year-old person is 91%. If you live to be 100, everybody has CKD. It is inevitable, like dying, that you will get CKD. Does that help the 91-year-old person who has CKD stage 3? I don't think so. So I'm arguing the provocative side of the equation that the arbitrary choice of a single absolute non-age stratified threshold for GFR has led to a substantial overdiagnosis of CKD, particularly in the elderly. Well, some might argue, well, it doesn't make any difference if it's healthy or not healthy. Having a low CKD, low GFR is bad for you because it increases your risk of developing cardiovascular disease. You've heard that before. CKD is a surrogate for CVD. Well, that's not quite as true as it's been advertised. In fact, if you add CKD stage using eGFR to traditional risk stratification using Framingham risk scoring in subjects without CVD, it does not improve one whit the correctness of classification of CKD rich risk. That's been looked at. Here's a study which I could have used any of several slides. This is from Sweden. This is elderly women aged 75 to 85, all of whom had eGFR assessed by reference methodology, and then their stage was related to risk of dying or having cardiovascular disease. And no matter what the formula was, there was no increased risk relative to patients who had eGFR greater than 60. However, once you got down to stage 3B, that's an eGFR less than 45, the risk did increase. So 45 seems to be a much better threshold for defining CKD in the elderly than does 60. 60 just, it's like a fishing net. It gets a lot of dolphins and other good things in it when you wanted to catch just the sea bass. What are the values of eGFR that define increased risk? Now, this is a little complicated slide. The one on the top, I've given you 4 age groups, 18 to 54, 55 to 64, 65 to 74, and over 75. And on the left is an eGFR, and I've given different reference values depending upon the age of the subject. These reference values are selected for what is the average GFR in that age, in normal subjects. You'll note in the white there is no real increase in risk until you get down into the less than 60 milliliters per minute, particularly less than 45, if you use an age-sensitive threshold. This also shows that high GFR is not necessarily good for you. Hyperfiltration increases your risk, and if you happen to be young and your GFR is less than 75, you're at increased risk of dying. So not only does the strata of 60 milliliters per minute for 1.73 meters squared not applicable to the older, it tends to underestimate the risk of dying in the young. Here's another slide from a very nice publication, Lancet, showing in dark green residual life expectancy by age on the horizontal axis, according to, and this is years left of life. Obviously, if you're young, you have a lot of years left, and if you're old on the far right, you have very few years. The two green lines are patients who have eGFRs over 60 and eGFRs between 45 and 59. Not much difference in life expectancy, but when you get below 45, yes, it does impact life expectancy. So what are we going to do about this overestimation of CKD in the elderly by using this single arbitrary threshold? Well, let's change the threshold. It sounds simple. Just change the KDIGO guidelines at the 45 to 59 group without albuminuria to a green if you're over 65 and a yellow if you're under 65. That's a simple, easily done strategy. If you did that, the prevalence of CKD in general would decline from 13% to 5% or less. You would cure CKD in about 20 million people by one simple maneuver. Unnecessary referrals to nephrologists for evaluation of possible CKD could be reduced by 70% or more, and overdiagnosis in elderly could largely be avoided. So my conclusion is that it is time to adopt an age-adapted schema for the diagnosis of CKD. If resistance continues to this change, we will continue to overdiagnose CKD, and in my opinion, KDIGO got it wrong. Thanks very much.